stop that progression of atrophy, but they're not going to get that atrophy. They're not going to get that muscle back. So watch that progression. It's like if they come in and tell you, oh, you know, doc, whatever you did, it was great, the pain's gone, but now my whole arm's numb. Okay? That's not a good thing. That's actually a bad thing. That just means that it's turned from pain fibers to you know, paresthesia, and then paresthesia into atrophy and weakness. So you know, you can follow them for a certain period of time, but don't sit on it too long with regards. But again, knowing your dermatomes, knowing what muscles are affected by which nerve root, knowing your deep tendon reflexes are going to help you figure out what's going on. Treatment as usual. We've been through this, so I don't need to go through it again. We didn't talk about neuropathics before because we really weren't talking about radicular symptoms. People who have radicular symptoms, if you can use neuropathic medications, use them. Because one, they're not narcotic. Two, they're not usually addictive and they don't cause all symptoms. And three, if they help with the patient's pain, they're not going to be fussing at you for narcotics if their pain's better. So the use of things like tricyclics, amitriptylines, some of the older stuff, but remember the side effects of medications. Gabapentin, Lyrica, two medications, you know, that are good, and you can start slow, titrate them slowly, get them to work from a neuropathic standpoint. But again, every time you add a medication, you're adding side effects. So, you know, watch them for the side effects that occur to it. Particularly those neuropathics, as far as gabapentin and Lyrica, on weight gain. They work in the level of the brain that tells the brain, the satiety center, that you never are satisfied with what you've got to eat. You need to eat more. So the medicine doesn't put on weight, but the medicine creates a condition that makes you eat more, which then puts on weight. So explaining that to the patient, you know, you still got the same plate, it still needs to be filled with the same amount of food. Don't overeat. Don't let your brain rule what things are going on. Cymbalta seems to be working really good. For a lot of patients, I have a lot of patients on Cymbalta because they can't tolerate Neurontin or Lyrica because of sedation. So I put them on Cymbalta and they do pretty well. So using those kind of medications in radicular symptoms can sometimes just kind of quiet things down until you can determine whether or not they're going to stay forever or go away. Conservative, again, you know, activity modification, low impact exercise, physical therapy, home exercise programs, acupuncture, chiropractor, all that kind of runs in that category. Pain management, lots of different things that you can try, or they can try. Epidural steroid injections. Remember, two medicines in epidural steroid injection. So one's a numbing medicine. So if they come back and they say that, well, it felt great, doc, for 2 days. Okay? Didn't have anything to do with the steroid that's in it. It was the numbing stuff that they put in there. And the steroid's going to take 3 to 5 days to work. The bad part is you shouldn't have more than 3 a year. So from there, if you only get 2 weeks worth of response to it, and you can have 3 in a year and you get 6 weeks worth of relief, what are you going to do for the other 46? So, you know, if they're not getting months of relief from epidural steroid injections, probably not going to help. Selective nerve root blocks, a little harder to do for a pain management doctor, kind of, sort of. A little bit more painful to the patient, but very good diagnostic tool. So if you think they have multiple levels, that you think that it's coming from the right L4 nerve root, you can have a pain management doctor go in and do a selective nerve root block on the right L4 nerve root. And if they do that and the pain goes away, then at least you know that the chances of you doing surgery and opening up that right L4 nerve root, you're going to help the patient. So they can really help. But most pain management doctors don't do them under sedation. And boy, that needle pops up against that nerve root to know that they're in the right place. The patient's not going to be real happy with you for setting them to that. But sometimes we can use a little Versed or a little something that at least they don't remember it. They still scream, but they don't remember that they screamed later. Also things, facet injections. You know, you got facet hypertrophy or facet effusions, going in and draining that effusion out of there percutaneously. They're a pain management doctor, an IR doctor. Doing facet injections, just like you would do an injection in a knee or a shoulder or whatever, and put some steroid in that joint, sometimes can help. Radiofrequency ablation, this nerve that comes out has what's called a medial branch that breaks off of that. That medial branch goes and innervates the facet. Okay? They can actually do a radio frequency or heat ablation to that nerve, to that medial branch, come into the facet and knock off the pain receptors that go to the facet. It's a peripheral nerve, it's going to grow back, so the pain will return. Second thing is you've got to remind the patient, you've done nothing to fix the pathology. All you've done is sever the nerve so that they don't feel the pain. So that doesn't mean that they can go back out and do stuff that they shouldn't be doing, because they're still going to continue to hurt themselves. They just can't feel that they're hurting themselves. So be careful of that. Surgery, laser surgery, it's a biggie. I'll tell you that if you go to Laser Spine Institute, patients will go over there, we'll read your MRI for free. Okay, well, they'll read your MRI for free, but they do not submit insurance. So you're looking at $10,000 to $35,000 upfront. And people do it. And then they come to us later and say that it didn't work. It's a big thing right now, but most insurance companies won't cover laser. And even the guys that are over there, they don't do fusions over there, but even though they tell you that they're going to do laser, most of the time they'll do a laminectomy through a tube, or they'll do some percutaneous things with regards to the fact that you still just have that small incision, but they're still doing back surgery. And back surgery that usually would be perfectly paid for by your health insurance company, but they won't submit health insurance usually. So from there, just warn your patients they can go get an opinion, but I would get an opinion somewhere else also, and see what other multiple opinions get. Patients always come into us worried that if they get multiple opinions that we're offending them. I said, if something's wrong with your car, you take it to more than one place to see what they say with regards to it. Your spine's no different. Get as much knowledge as you can. The more knowledge that you have, the better off you're going to be, and the more likelihood that what we do will work. If people keep telling you the same thing over and over again, well, it's probably what you need to have done. But if, second opinions do not hurt my feeling in the least. Foraminotomies, hemilaminectomies, discectomies, the biggest thing that I can say of that is that is to relieve nerve root compression. So if you've got a radicular symptom going off in the leg, it's going to help your leg pain. You've done nothing to the disc. Well, you've removed part of it, but you've done nothing to the entire disc. You've done nothing to stabilize the spine, so those patients will probably still have low back pain, or will continue to have back pain. But if the majority of their symptoms are radicular in nature, and what you want to fix is relieve the pressure off of the nerve root so that they don't lose strength or atrophy into that nerve root, that's what they need, particularly in young people. The things that you have to watch for that really happen frequently, discectomies, reherniation. The 26-year-old that lifted at the deadlift at the gym, herniated a disc, came in, got a discectomy done, 2 weeks later felt great, invincible 26-year-old muscle brain, goes back out, does it again, reherniates the sucker right back out again, okay? You have to disrupt the annulus to get to the disc unless it's an extrusion and you can just grab the extrusion. If you disrupt the annulus, that annulus has to heal, and it takes a good 4 to 6 weeks to heal it. If it doesn't heal, there's still nucleus pulposus sitting in there, and you squeeze it down and pop it right back out again. The other thing you have to worry about, particularly in people that have a spondylolisthesis, that you just created an iatrogenic destabilization or instability in that spine. When you do a hemilaminectomy or a foraminotomy or whatever, that bony structure, you're disrupting it. And if you disrupt it enough or you get out into the joint, you're going to create an instability in the spine, and now you've just made the problem worse. So that's something that we have to really look for. Disc replacements, we talked about that already, works better in the cervical spine. Fusion, that pretty much announces itself. You have a true instability, you have a true spondylolisthesis, you have issues from a standpoint, you're just going to have to fuse it. So that's an axial and a sagittal film of stenosis. So when you look at an axial view, your central canal should be right here. Okay, there's not much there. When you look at it from a sagittal position, lots of connection from what's going on. A lot of times in stenosis patients, What you will see is what's called spaghetti sign. And that's basically, remember when you come down into the lumbar spine, you've got the conus that's sitting up at L1, sometime L1, L2, and then you've got your cauda equina, so you've got all these just loose nerves that are coming down. If I crunch that area in a specific spot and turn a hole this big into this big, well, all those nerves just pile up behind it because they can't get through. So you'll have this, kind of crazy looking stuff that like you're trying to thread spaghetti through a strainer and it's all backed up. So that's a good area to see. You start seeing all that clumping of nerves that are sitting there. You got to release those nerves or you're going to have issues with regards. Spinal stenosis is typically a degenerative condition. It's progressive. In other words, your patients will come in. My favorite one was at the VA, and his comment was he refused to have surgery. He's a Vietnam vet, refused to have surgery. As long as I can feed my chickens, I'm good. And I saw him for almost 5 years. And finally his grandson came in one day, and his grandson kept shaking his head, and I was like, okay, what? Because I would come in, the first thing I'd ask him is, how are the chickens? Are you still feeding them? Is everything still good? Yeah, everything's fine. I'm like, okay. He went, and it's probably, I think his grandson said it's about 200 or 300 yards from the back door of the house to the chicken coop. He went from walking out to the chicken coop, so in that 5 years, 16 chairs lined up between the house and the chicken coop. So he would walk from chair and sit and rest, and walk to the next chair and sit and rest, and walk to the next chair and sit and rest. So he could still feed his chickens, but that's what he had to do to activity modification to do what he needs to do. So that's the kind of thing that you see. How far were you walking last year? How far can you walk this year before you have to sit down and rest? These patients will get better in forward flexion if you have them bend forward, or you'll say, so do you find yourself leaning on things all the time? My kids laugh at me because I walk around in the grocery store. There is actually a sign that's called a shopping cart sign. Okay? It's a medical term with regards, and it is spinal stenosis. And you'll see people walking around shopping, and they'll start that first line, and they're going along, and the next one they're sitting there like this, and the next one they're like this. Okay? And that you'll watch them, and my kids will go, are you going to just go hand them your card? Or think about it. So that's area that you will see, and that's all mentioned on this next slide. Reflexes are going to be down. Okay, they're not going to have reflexes with regards to what's going on because they don't have any nerve input getting down to the reflexes to give them. Shopping cart signs, progressive. How far are you going? What's going on? How is this progressing? What's happening? These people respond pretty well to epidural steroid injections early, and they may get one and for 5 years be fine. But then they'll come out and they'll go, well, I got the next one, and it lasted me 6 months, and I got the next one, and it made it worse. Well, again, you got a hole that started out this big, and now it's this big, and I just crammed 20 cc's of fluid into that little hole. Yeah, it's going to get worse because the nerves are even more compressed than what they were before. So those are the areas that you have to watch for. Water therapy, these people work great in water therapy. And a lot of those Advantage programs, the Medicare replacement program things that are out there now, are requiring 6 months of water therapy before you go. But they won't pay for gym memberships, and they won't pay for anything else from a standpoint of get them to water therapy. So, double-edged sword. Older people, people who aren't very active, people who have bad medical conditions that they're not going to do well under anesthesia, decompressive laminectomies are fine. You do multiple level decompressive laminectomies at a 56-year-old who still wants to go do everything that they thought that they could do when they were 20 are going to fall apart. So those patients are the ones that you have to worry about doing decompression fusions on. Cauda equina syndrome, we talked about it a little bit. This is what it looks like when you get it. I mean, these herniations, that's actually 2 of our patients. These herniations are huge. Okay, the first thing you do is pull up that MRI scan and you go, ooh. And these are the ones, particularly if they're having lower extremity weakness, bowel or bladder complaints, saddle anesthesia, they need surgery today. So stop what you're doing, put your patients on hold, call the OR, get them in. Okay, because if not, they're not going to get it back. So again, like we said before, true spinal emergencies, cauda equina, foot drop. Those 2 things, if you don't fix fast, you're going to be in trouble. Foot drop, inability to dorsiflex their foot, so as they try to step on up onto things, they keep falling down. Get them to heel lock. You know, if you don't think from a standpoint, or just watch them. I made a true foot drop the other day. It was crazy. So she was laying in bed, and this foot was like this, and this foot was like this. I mean, I was like, lift your foot up. She was like, can't. So one day, perfectly fine, then the next day, not. The only thing that we figured out that had happened, because her spine looked fine, the only thing that we figured out has happened is she just had this knee replaced, and she fell, and when she fell, she landed on this knee. So we think we have a perineal nerve injury from an actual direct contact to the perineal nerve coming out of the knee and caused her to drop. But, I mean, it was, I've never seen it that drastic. I mean, it literally, I mean, her foot would just flop. So it did move. This is another one you don't want to miss. Cervical myelopathy. People come in and say, Doc, I'm walking funny. You know? They don't tell you about anything else with regards to their neck pain, their hand weakness, the fact that they can't do anything with their hands, and how it's been like that for years, but now I can't walk, or I walk funny. These people have that kind of cerebral palsy walk. It's that real choppy. I mean, it's obvious. They come in and you go, take a walk down the hall, and you look at it and go, oh. 9 times out of 10 in our office, they'll come in with an MRI of the lumbar spine. And they'll come in and with an MRI of the lumbar spine because they went to their doctor and their doctor says, I can't walk. And their doctor says, oh, something must be wrong with your back. And they get an MRI. They didn't look at them when they saw them walk and realized that that's not a normal, you know, that's not a normal gait. That's not an antalgic gait. That is a myelopathic gait. They're obvious to see. If they have a myelopathic gait, oh God, you have to get a cervical MRI now. Okay. One slip and fall, one domestic dispute and they hit their head, one rear end car accident, they're paralyzed. So that's something that has to be done. This is progressive. They didn't just happen to get this on a day. This happened for a while. But what they didn't tell you is that over the last year, they've not been able to hold a pen correctly. They drop things, they crush things. Okay, so they pick up their coffee cup, they don't know how, they lose your proprioception in your fingers. They can't button shirt, they can't zip their pants, they can't do those kind of things. So from a standpoint of when you're talking to people about neck pain and they come in and start talking about things from a standpoint, assess to make sure they don't have that early myelopathy that's going on. Because that early myelopathy, if we can catch it soon enough, some will come in and say, well, I can't write checks anymore. Like, why can't you write a check anymore? Well, they can't hold a pen in their fingers to be able to do it. Or they'll come in and they just wear t-shirts anymore, they don't wear button-ups. Well, instead of telling somebody that the reason that they're not wearing a button-up is because they can't button their shirt, they just change it to a t-shirt. So those type of things are important because their risk of having paralysis from a tiny little thing. I had a guy come up from Louisiana after the tornado or the hurricane that hit Beaumont, Texas. His house was destroyed. He came up and stayed with his family in Edmond and for several months while they were repairing his house. And he felt bad for staying in the house, so he decided he would paint the entire exterior of their house while he was there. So he painted the entire exterior of their house, did great, didn't have any problems, wasn't having any issues whatsoever. On the day he was leaving, they have a porch that was up, and he was kind of saying goodbye and was just kind of backing up and fell off the porch. He spent the next 6 months in rehab, paralyzed from the waist down, well, more or less from the chest down, because it was a C6, C7 injury from a standpoint, but you know, pretty much from the chest down. He still had the use of his arms, but pretty much from the chest down, until we could get him stabilized enough to be able to come in and do his surgery. Had to do anterior and posterior surgery on him and stuff before we could send him back to Beaumont again. So something silly and stupid as that, and when we questioned him, he'd been having issues, but he didn't want to bother anybody with it. He didn't want to tell anybody. I don't know what's going on. So physical exam, watch for your myelopathic gaits. So have them walk down the hallway. You'll notice it. They walk funny. So it looks like they're drunk. They'll bounce from wall to wall. You'll tell them that a lot of them won't go to movie theaters anymore. They won't go to movie theaters anymore because they can't see in the dark and they can't feel with their feet because they have no feeling on the bottom of their feet. And so they can't walk out of the movie theater because they don't know where they're going. So they just won't go. Symptoms are worse when you extend your spine. So, just think about it, if I take that disc or that whatever's causing the compression and I push it back into the spinal cord, things get worse. So if they look up at something, most of them will tell you that they get almost like electrical shocks that run down their arms because of what's going on. Decreased proprioception in the hands, spinal cord, central nervous system. So you gotta look for upper motor neuron signs. They're gonna have hyperreflexia, they're gonna have a positive Hoffman sign. Those type of things are going to lead you to believe that it's a spinal cord compression, and those you have to relieve. Treatment, surgery. I mean, just nothing else you can do. If they have signal change in the cord on the MRI, so they have myelomalacia in the cord, there's a chance they're going to get better, but they still may have issues. That cord's been damaged. There's nothing you can do. Tell people it's almost like putting a bruise on the cord, and there's really nothing we can do to relieve that. So. We've got to do surgery. Surgery at multiple levels may need to be posterior. Fewer levels we can do maybe an ACDF. Most of the time with these though, not only is it disc that's going back, but actually, if you got a normal lordosis that's like here, your spinal cord's here, and you got your cervical spine here that's in that normal lordosis, but you got one bone that's either in a reverse lordosis or straightening from standpoint. Even doing an ACDF and trying to bring that out, you're not going to be able to get it. We'll actually have to go in and do a corpectomy on that bone that's actually pushing back and open that area up. So we do lots of corpectomies. I'm not going to go over fractures a lot. You have it in here. I'm not going to go over fractures or tumors that much, but we'll talk about kind of the ones that are most important. Compression fractures are the most common. Obviously, you're going to see them a lot. They're usually in that thoracolumbar junction or in the thorax. That's usually where you'll see the most of them. And then we have the rest of them, and I'll kind of go through those quickly. Compression fractures are going to obviously help, more in the elderly, more in people with osteoporosis, more in females. But you also have to look from a standpoint, is it an RA patient that's been on steroids for 20 years? If that's the case, that's going to break down their bone and they're going to have problems. So they may only be 50 years old and you think, oh, you're not old enough, but you find out that they've been on 20 milligrams of steroids every day for 20 years. You're going to have that. Also trauma, obviously, will cause those issues. Usually with most of these people, you can treat them conservatively. You can brace them for a while and they do better. Send them to your bone health people. Fortea, which I'm sure Heather will talk to you a bunch about today, is a recombinant parathyroid hormone medication that's out. There's a new one that's actually out on the market too. They've been known not only to actually restore bone, which some of those other ones from before have not, but it's not indicated for pain, but there are actually several studies in there that have shown that these patients do really well with Fortea with pain. So that's one thing that you do. Obviously, vertebroplasties or kyphoplasties, do a vertebral augmentation that will kind of help build the strength of that bone back will help. If all else fails and it's really busted up, then you may have to actually come in and do a fusion around it just to help stabilize the spine. Different fractures. Jefferson fracture is a C1 ring injury. Okay. It's usually caused by an axial load, so it's like something that just like smacked on top of the head really fast. Remember that C1 is going to sit just right at the base of the occiput, and if you push things hard enough, you're going to create a C1 fracture. The biggest thing that you have to worry about that is a couple-fold. One, there's going to be vertebral artery injuries, because your vertebral arteries are going to run right up through there. And you can have a vertebral artery injury that you need to watch for with regards. The other thing is that usually if you have that fracture, you better be looking for a C2 fracture too, because you've likely, if you've hit it that hard, you've probably hurt a Dens fracture as well. Most importantly, if that happens, then you've got to really look and see what's going on to the ligaments that actually come in and hold C1 to C2. Because if you've got a Dens fracture, C1 fracture, and a ligament injury, that patient's going to die. So you've got to halo that patient and stabilize that patient fast. Dens fractures or odontoid fractures, those are C2 fractures. They come in all different varieties. You see type 1s a lot. And that's just kind of the tip of it broken off. They're okay. They'll be all right. It's going to take a while. They may always look a little funny. It may always look like they have a chronic fracture there, but they're going to be okay. When you get into the base, or you get through the lateral mass that's back there, then that's when you have to really worry about ligament injury and whether or not those people are going to be paralyzed. Hangman's fracture, not really a hangman's fracture, it's a hangee's fracture. It's the person that's hung themselves with regards to what's going on, and that's that, that rapid area where you have actual distraction that's going on. You've got a hyperextension of the neck and an extraction that's going on, and basically it's usually between C2 and C3, and C2 just literally just falls right over the top of C3. Sometimes it's okay. That spinal cord had enough room that it's all right. Other times it's not okay, and the person dies. Teardrop fractures comes in two different forms. One's an extension fracture, where you just kind of, remember we said that there's the anterior longitudinal ligament that sits on front of the spine. If you have a fast hyperextension injury, that ligament can actually just kind of grab a piece of that bone and just avulse a piece of the front end of that bone off. And that usually, it looks pretty dramatic on an x-ray, and everybody kind of freaks out about it, and the emergency room will be calling you quickly about it. But it really doesn't ever really do much of anything. You usually put the patient in a collar for pain and don't worry about it. The flexion injuries, though, are the ones that you have to worry about, because those are the ones that usually, it's lower in the spine, so it's not a hangman's fracture, it's not up at C2-3, it's more down at C5-6. And it's that rapid, just basically somebody just took your head and just boom, nailed it down. And because it's usually fairly close to the cervical thoracic juncture, so that way you get a lot of that injury, and it's usually down around the 5, 6, 6, 7 area that you'll see it. Those people come in paralyzed. I mean, you can put them in a halo, you can put them in traction, you can see if you can reduce it, you can go in anteriorly and posteriorly and fix it, but usually you don't get that paralysis back. It's there. Lumbar fractures that we look at, chance fracture. These people do pretty well in just kind of conservative therapy. Not usually will they have to have a lot of surgery done unless they're sitting up somewhere around L1, L2. If they're sitting up there and you've got disruption of any of these processes that come in and affect the conus, then you have to worry about the fact of, are we going to have a conus injury? Do we need to fix them so that they're not paralyzed? These are most patients, you'll see a lot of these in car accidents. So it's I'm completely seatbelted in and the car stopped and the body kind of, went forward and jerked with the lap belt. People come in and these are missed a lot. And they're missed a lot because the patient's bruised, their belly's just bruised and beat up and, hemorrhaging with regards to what's going on, and everybody's scared to death that they've got internal injuries because of the seatbelt. And then they forget after that of when they figure out whether they either rule them in or rule them out of intra-abdominal injuries, they forget to look at the spine. So a lot of these are found actually on CT scans where they did a CT of the abdomen and pelvis. And, well, don't forget, you're going to see the spine on there too, and the radiologist looks and says, oh yeah, by the way, they have a chance fracture. Most of them, like I said though, if they're neurologically intact, you can treat them conservatively and they'll be okay. Burst fractures are compression fractures, but usually compression fractures that we see in younger people because of my 16-year-old silly football player in South Oklahoma that decided to jump off the bridge into the pool of water because all of his friends were doing it, and he missed and landed on his feet, on the shore on the other side, and basically took a compression fracture and just smashed the bone. And when he did, the fragments of that bone are sitting back in the canal. If the fragments are sitting back in there, you've got to go in and clean that up and fix that. That's usually, sometimes you can brace them, but the majority of the time we'll fix those. Coccyx fractures we talked about before, they happen a lot. People fall down and fall flat on their butt and they break their coccyx and it hurts and they better be sitting on cushions for a while. Coccygectomies, I guarantee you, I don't care how perfect of a patient is, how thin they are, how well they bathe, how good they are. 100% I can almost guarantee you they're gonna get infection. And then you're bringing them back in, and then you're putting a wound back in, and then, I mean, it's just, it's an easy surgery. It is so easy to go in and make an incision this big and find that broken coccyx and pull it right out, but it literally is right in the crack. So I can guarantee, and I mean, I've tried doing the whole, you know, bidets and, you know, let's keep this really clean, and it doesn't work. So now every time it comes in and the patients are crying, please, 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 you have to fix it. And Scott comes out of the room and he's like, but she's crying. And I go, I don't care. You can't, I mean, if we do this again, I mean, it's, you know, because then they cry for 8 weeks afterwards because now they have an infection. So it just, no, don't do it. Refer, this is just a few things. This is just something, I mean, just because somebody's having back pain, don't think it has to necessarily be their back. You know, don't forget an abdominal aortic aneurysm, best presenting sign for that is back pain. So don't miss those kind of things. Pelvic disease can come through, gastrointestinal diseases, pancreatitis, peptic ulcer disease. All these people can come in and all they're complaining about is back pain. They don't complain about anything else. Kidney stones, kidney infections, same thing. They can come in and say, you know, their back hurts. And it's not really their back. I'm almost done, I promise. Neoplasias, again, these are still small things, but they're things that you have to think about. You know, is there a cancer? Inflammatory arthritises, you know, ankylosing spondylosis, irritable bowel syndrome, autoimmune arthritises, those type of things are something else going on. With regards to neoplasia, multiple myeloma, I actually see quite a bit of it. It's an overgrowth of the plasma cells, actually in the bone marrow of the patient. They have bad bone pain, but it's not, when you get their symptoms, they hurt all over. It's not just one area, they hurt everywhere. So then you kind of have to think, you know, well, this doesn't make sense. It doesn't link to anything. What's going on? They may have white blood cell count abnormalities. They may have pathologic fractures where they have compression fractures that you don't know why. A lot of them will have hypercalcemia because of what's going on in their bone. Some of them will lead to infection. Some of them present actually with kidney disease that you'll present it from there. It's a blood test. So, you know, and serum electrophoresis, Bence-Jones proteins, those type of things. That's certainly something, and then obviously, you know, they have to go to a hematologist to kind of figure out what's going on. The MRIs, when you look at them, are pretty pronounced most of the time. So you get these really areas of just modeling of the bone, where the bone density just looks bizarre and different. And those are the patients, and a lot of times, like I said, you'll get compression fractures that are there. So don't rule out, because it's an easy thing to kind of look at. You know, if they just come in and it's really nonspecific and you've done everything and you can't make it go away, get a blood test and see if that's a possibility that they've got something that's going on. Metastatics, bone is the third most common place for a metastatic tumor, so you'll see metastatic tumors in bone a lot. Intradural mets, so mets inside the spinal cord itself, are pretty rare. Most of them are sitting in the bone. They're going to be lytic lesions, so unlike a tumor in the bone, which usually when you put contrast to it, it's going to light up, these things are going to be, it looks like the bone's just been chewed away. It literally, I mean, there will be times that I'll be counting bones and I'm like, wait a minute, we're missing an entire bone. Where is it? And it's not there. And you go in and it's literally, it's not there. It's just brown mush sitting in there from where the bone was. So it chews up the bone pretty bad. Lung, breast, colon, those are usually your big three. You can do lymphomas. You can get a lot of lymphomas from a standpoint, and melanomas late will go to the bone, but you know, lung, breast, and colon are usually your three biggies. Most of them are in the thoracic spine. I don't know why, but they are. You'll see the majority of them will show up in the thoracic spine. Surgery, if you know the patient has a life expectancy that's reasonable, and they're in so much pain that they're a mess, you can go in and fuse around that metastatic bone. If there's only a single one or two, you can go in and do it. If there's multiples, usually palliative radiation is about your only choice that you can go in and try to do to see if you can get it better. Spinal cord tumors, again, I'm not going to go through these that much because if you see a tumor, just ship them out. Extramedullary and intramedullary, obviously something that comes, outside of the spinal cord or that's actually generated inside of the spinal cord. The ones that are outside of the spinal cord, a lot of times they're benign, but they're pulling on a nerve root or they're pulling on something that's actually causing the patient pain. So you have two kinds of spine doctors, right? You've got orthopedic spine surgeons and you've got neurosurgeons. These have to go to a neurosurgeon, okay? I tell people from a standpoint, when people ask me what the difference is between the two, to me a neurosurgeon's an electrician and an orthopedic surgeon is an architect. If you've got bony malformation and you've got stuff, and I've worked with both, so you've got bony malformation, you've got things that structurally don't look good and it's a bone structure issue, that's what your orthopedic surgeons are trained in. They're trained in bone. They're trained in modeling a bone and getting the bone back to where the bone needs to be, things that are going on. Now, luckily when they do all of that, hopefully we release most of the nerves too, but they're really good at what they do with regards to bone. Or neurosurgeons, they spend a majority of their time with brain tumors and spine tumors and things from a standpoint, and they're really good at dealing with things intradurally. Orthopedic surgeons can't even do it. They're not supposed to. They've not been trained in it. We do it, I send it over to, if we see one, I send it over to a neurosurgeon. Just right there. I pick up the phone, call Rob Winnicke and say, Rob, that patient coming your way. Okay. But from that standpoint, that's kind of, two people are out there that are fellowship trained in spine, but they're trained a little different. So look at it that way. Intramedullary ones are typically bad news. Vertebral tumors, like we said, metastatics that'll come through. You've got benign tumors and malignant tumors. So those just have to, again, if it's a bone tumor, if it's not in the canal or in the cord, a bone tumor can go to either one. I mean, you just got to do a biopsy on the bone, pull it out, send it down to pathology, and find out what it is. And then from there, you just figure out where you go from there. Inflammatory arthritis, the biggest one that you'll hear from boards and stuff are going to be ankylosing spondylitis, bamboo spine. Okay, happens more in men than women. Usually starts in about their 20s. Typically, will start with sacroiliac pain. Okay, because that's the first thing that fuses. Usually morning pain, usually stiffness. So a lot of these people you'll see through rheumatology, because it's like, they can't get going in the morning, they can't do things, so a lot of rheumatologists will see. HLA-B27, this test, that'll be on boards. Bamboo spine, so when you see these, it looks like that spine is just kind of, just got these two rods that have just kind of auto-fused right through it, and it's really hard when these patients get further and further along. You literally can't tell where one bone stops and the other bone starts. It just looks like a big column of spine that runs through there. These people need to go to, don't fuse them, don't mess with them, it'll make it worse. But they need to go to a rheumatologist and start on medications. And then last but not least, that's not associated with the spine, but stuff you will see that you kind of remember that, okay, so patient comes in and they complain of hip pain, okay? Well, if their pain's in the groin, it's hip. Okay? If pain's out here in the side or comes across the butt, it's nerve. Or if they can't lay on that side, or every time you touch or their pants or anything hits right on the top of that greater trochanter, it could be just a trochanteric bursitis. You inject that bursa on the trochanter, it goes away, and they're fine. They don't have any problems with it whatsoever. Okay? So don't necessarily think, oh, they got an L5 nerve injury, from the standpoint. They just got trochanteric bursitis. Inject the bursa, send them on their way. Sacroiliac joint pain. People come in and complain of pain right here. It just hurts right here on one side or the other. Okay? Have them sit crisscross applesauce, have them sit, from a standpoint of, I can't do that because I have sacroiliitis on that side, but have them pull the leg out from this direction. Leg in this way, Hawkins, that's hip. Leg out this way, that's pulling at your sacroiliac joint, and it's sacroiliitis. So, physical therapies, non-steroidals, injections into the SI joint, those can help, that kind of stuff. Piriformis, you got somebody that comes in and says, I hate this word, I have sciatica. But you look, and there, my doctors looked at my MRI, my lumbar spine, there's nothing wrong, everything's fine. Your sciatic nerve runs right between your piriformis muscle, which hits from the ilium to the iliac, okay? As it runs right through there, it's gonna hit that nerve. The bad part about it is there's really not a lot you can do about it, other than exercises, stretches, injections don't work. You send a pain management doctor, they'll do a piriformis injection, but it won't work. And it hurts because of the location of the needle. So from that standpoint, don't think everything has to be related to the spine. You might have something else that's there that might be a fairly easy fix. I'm done. Questions, comments, concerns? We got a couple minutes. Does anybody want to know about the histories and physicals? Dan, I'm going to forward this email to you.
Okay.
Can you get it out to everybody?
Yep.
Okay. Let's see if I can find it first. So the dates that are still available, it looks like, what day are 10? Tonight they're at Rose State. Monday they're at Southwest Christian. You might know where that is. The 16th, which is at Wednesday, they're at USAO. But they're actually doing it at our Norman office. The 21st, they're at USAO. The 22nd, they're at St. Gregory's. The 23rd, they're at Southwest Christian. The 24th, they're at OBU. Okay? So I'll forward this to you guys. I mean, there's nothing like you can do from there. But what I'll do is have actually, everybody take down my email address. Because I'll give you my personal one, because if not, you have to go through our security system, and it's a pain in the neck. It's Tamin, Tamin, 0930 @gmail.com. Okay? Look at the dates, Tamin, Tammy Myers, 0930 @gmail.com. Look at the dates or whatever from a standpoint of what's going on. Don't respond back to the email that you're getting, because then you respond back and Ted's going to go, who are these people? But just send me on what days you would like to go, and I will get back to you individually. Almost all of them start at like 6:15. Basically, the thing that I can tell you, just so that it's like generic when you get there, they'll start at 6 unless I tell you it's different, okay? I will tell you where it's going to be. Once you get on campus, I can't tell you where it's going to be, but it's usually at the athletic department, okay? So, wherever the athletic department is on campus, you usually go from there. When you get there, there's always a long-ass line, and there'll be more later because we'll start doing high schools. But there'll be a long line, okay? Go past all the line, keep going, there'll be a desk that's usually at the front that's directing people on where to go, and just ask them, where's the medical team? And somebody will show you on where to go. So, that's usually the easiest way. Bring your stethoscope, okay? Because we don't have extra ones there. So bring your stethoscope, because that's where we go there. These guys will go through, or the girls and guys, the athletes will go through like a blood pressure check and all that kind of stuff first, okay? Then they'll meet with our trainers and go through, they'll do the majority of their musculoskeletal stuff, okay? So they'll go through that part, and then they'll come to you. The responsibility when they hit you is a couple of things. One is even though they've been to somebody to get their blood pressures checked and all that kind of stuff, they haven't told them what it is or done anything with regards to it. Okay, they're not medical, they're just probably one of the MAs in the office or whatever that's checking their blood pressures. So you gotta look at their blood pressures and their heart rates and all that kind of stuff to make sure that you feel comfortable where their blood pressure is. If you don't, you can ask them to go back, you can flunk them, you can make them get an appointment with their doctor to see what's going on. But a lot of these kids, yeah, you'll have a lot of these 8th graders even that I've seen that'll come through that have systolic blood pressures of 170. You know, yeah, it's bad. But it's because they're huge. I mean, these kids are gigantic nowadays. So blood pressures and stuff like that, watch for. The musculoskeletal stuff, you don't have to do a musculoskeletal exam, but remember, they're athletes. So if there's something abnormal on the musculoskeletal exam and you look back through their surgical history, because you'll have the little history form that they fill out, you look back through their surgical history and they've had an ACL repair or they've had things from a standpoint, you're going to have to question a little bit about, you know, who's your orthopedic surgeon, have you been seen by them, have you been released by your orthopedic surgeon, check their, you know, recheck it yourself just to make sure that the joint feels stable and things look good. If they don't, then call one of the sports medicine guys over and have them examine it and say, you know, hey, is this safe to let this go through? Make sure that they go through, you know, that if there are braces and stuff like that, that you've encouraged them that, you know, you need to follow the instructions on what's going on with regards to that. Then most of your exam is going to be a neurologic exam, so a rapid neurologic exam to make sure they're okay. Question the daylights on them on concussions. How many have you had? How long have you been out? What's going on? Are you having frequent headaches? Do you have visual changes? Do you have nausea and vomiting? So really get them good on concussions, okay? Because you don't want to put them back on the field if they're having a bunch. And then obviously, you know, heart, lungs, abdomen. I mean, just, you know, a brief physical exam after that, just to make sure that you feel comfortable that the rest of their system looks like it's functioning normally. But anyway, it usually takes about, we can usually pass through one in about 3.5 minutes. So, okay. So, you know, it's, and sometimes if you're not real comfortable, you guys can work as teams. So, I mean, you can, if you don't feel like, you know, I don't know if I'm real comfortable to do this all on my own and send them someplace, you know, the two of you can work on it together. They're students. They're not, I mean, they're going to get it if there's a student working on them. So they're okay. But those are the kind of things, so you don't have to do a whole exam because part of that's going to be already done. But you got to look at what's been done because they haven't seen a health professional yet. So all they've seen is a trainer or an MA or an LPN. So, you know, just because they went past that station doesn't mean that they passed it. They don't pass until they get to you. Okay? And then you'll have to take everything to one of the PAs or one of the docs or somebody that's there next to you. And usually we'll like do a big weight room and they'll just have this huge, like a room this big, and we'll have tables just set up and you just grab a table and, you know, next one in line to you, next one in line, next one in line, next one in line. Okay. So I will send this email out to Dan, and then if anybody's interested on a specific date, just email me so that I can kind of gather a number and answer any questions that you might have so that I can get it to the people in charge so that you don't walk in and they go, who are you? So they know who's coming. Okay? Questions with regards to that?
What were the dates on the week of the 21st or the 25th?
So the 21st, USAO, the 22nd, St. Gregory's, the 23rd, Southwest Christian, the 24th, OBU. Yep. Okay. All right, done.